Thank you. Good morning, everyone. Good afternoon, good evening. It's a pleasure to be joining everyone on this webinar. As you know, obstetric violence is a public health concern. It's not unique to the Caribbean, it's a global concern. And it is so because it is widely experienced with women facing situations of mistreat, disrespect, physical abuse, neglected care, verbal abuse, non consented care, and the list can go on. Several factors are associated with obstetric violence, and these have been analyzed. And they include, this is not a full list, just to note a few. Residency, for example, rural versus urban, where it is observed that more obstetric violence happens towards persons from the urban areas. Age shows that younger persons or younger pregnant persons are more likely to experience obstetric violence. Women living with HIV, which is the focus of our discussion here today, also experience obstetric violence. Obviously, like any other form of violence, there are consequences to obstetric violence that includes, and again, this is not an exhaustive list, but just to name a few, the kinds of stress, depression, and anxiety that this causes. But also, obstetric violence creates mistrust in the healthcare system, and this results in women not accessing services. And we know the consequences of this. The health sector is really central to this issue, and as stakeholders, policymakers, managers, service providers, we really do have to be intentional in addressing this issue so that women can have unhindered, confidential, consenting, non-discriminatory services, obstetric services. And again, today we will focus on how this affects women living with HIV. And so, on behalf of Dr. Wendy Emmanuel Telk, the PANCAP director, I want to welcome you to this important discussion and conversation that we'll have this morning. I look forward to everyone's active participation and to some very robust discussion. This is a very important topic for all of us in the region. Again, on behalf of Dr. Wendy Emmanuel Santel, I want to thank all of the presenters for sharing, and I want to thank all of you for being here with us this morning. Thank you and welcome.
Thank you very much, Dr. Shadi Singh Anthony, Coordinator Mothers Management here at the PCU. We would like to continue with our agenda and ask Dr. Richard Amenya to bring us greetings this morning. Over to you, Dr. Richard.
Thank you very much. My namesake Richard. Good morning, distinguished participants and partners in the fight against HIV. It is indeed a great pleasure for UNAIDS to be collaborating with PANCAP and ICWW in this very important conversation on obstetric violence, which Dr. Shanti Singh has just eloquently talked about. Indeed, obstetric violence, from our perspective, is for us to educate people to have a deeper understanding of how it impacts on women. We see it as a form of gender-based violence. It's a violence against women in their reproductive age, and it is critical for us to highlight this issue as part of our collective Caribbean response to the HIV epidemic. Because many a times we have heard about issues concerning violence against women, and it is important to understand the scope of this challenge that we are faced with. There has been instances where people have been asked to even go into sterilization and all that. This kind of issues have come up in different countries across the Caribbean region. And that was the motivation for us to shed more light through this partnership with UWI to help us have a greater understanding of what the issues are, especially with ICWW on this very important matter. we see it as a way of trying to address issues around health disparities that women face, particularly women living with HIV, and what we can do to help improve on maternal reproductive health services across the Caribbean region. In terms of manifestation, as Shanti did mention, there is a lot of disrespect that is associated with having a disease that is incurable, and people feel abused and not dignified as far as the services that they receive are concerned from our healthcare providers during childbirth or even during antenatal sessions. And it is important for us to highlight this issue, that it is a violation of the rights of the woman, and it tends to perpetuate the structural inequality that prevent women from actually attaining the type of healthcare outcomes that we expect, especially when they get pregnant and are expecting. It is also very important for us to know that women living with HIV and marginalized key populations are often the most stigmatized people, and there are medical procedures that because they don't have their rights respected, tend to be flouted. And it is important for us as policy people to highlight this issue and strengthen the autonomy of women, regardless of whether they have HIV or not. And that is why, for us in UNAIDS, we are very much interested in ensuring that all health policies are protective of all women. And it is a way of advancing health equity across the Caribbean region, and also advance gender equality in our region, because these are the foundations for ending AIDS as a public health threat. And so I hope our conversation today with the experts will help us look at policy initiatives that we need to look at as far as health policymakers are concerned. What are the legal issues that we need to be looking at, policy reforms that we need to put in place in our regions? How do we ensure that we are expanding comprehensive sexual reproductive health services that are right-based and gender responsive? And most importantly, opening up the space for community conversation and advocacy. I think that is where most of us are critical, because we will be in different policy tables that we need to be able to champion issues around obstetric violence. And all in all, it is about how we influence the social determinants of health as it impacts on everybody. And I hope that our conversation will help us table the issues and help us sustain the advocacy in protecting all women. Thank you very much for this opportunity. And I'm really very eager to listen to what the outcomes are. Thank you.
Thank you very much, Dr. Richard, for those very inspiring words that you just gave us. It's now time to get down to work. I haven't seen Dr. Michelle here on the apples yet. I'm not sure why she's not here. But we're going to move straight into the program. We have two presentations. We're going to ask that you type your questions in the section, mark for questions, and we will deal with the questions after the two presentations have been made. We head to the first one now. Our next presenter is a senior research fellow at the Institute for Gender and Development Studies Regional Coordinating Office at the University of the West Indies in Jamaica. She's engaged in research, teaching, and policy work. Her commitment to a regional development process is shaped by a gender justice lens, which is evident in her scholarship, advocacy, and her use of feminist and gender research approaches for Caribbean social development and policy. Her areas of research include migration and development, diaspora issues, gender and climate change, gender-based violence, and Caribbean masculinities. Here to present Understanding Obstetric Violence in the Caribbean, I give you Dr. Natasha Motley.
Good morning, and thank you, Richard. Thank you for that wonderful introduction. And I'm happy to be here and be part of the conversation this morning. So, right, if you will just assist me as we go through this presentation. So we are going to look at obstetric violence against women living with HIV in the Caribbean and what is being done or what needs to be done to tackle this very important issue. So I'm going to give you a summary of, so a study was done, an assessment was done, next slide, in 2022 to 2023, and this was done in collaboration with the Centers for Disease Control and Prevention, CDC, the International Community of Women Living with HIV in the Caribbean, and UNAIDS Jamaica office. And this assessment was conducted in 4 Caribbean countries: Jamaica, Guyana, St. Vincent and the Grenadines, and Trinidad and Tobago. And mainly because these countries do have high prevalence rates of gender-based violence, and also they have strong networks of women living with HIV. So these countries were selected for the assessment. So the assessment was done to achieve a few things. First of all, and very important, to define and conceptualize what we mean by obstetric violence, because this is a relatively new terminology in the Caribbean space. And it was important to learn or to know or to understand how women living with HIV, which is the target population, how they define it, how they understand obstetric violence. Secondly, we wanted to identify and assess the factors that place different groups of women living with HIV at risk for obstetric violence. And this is because we recognize that women living with HIV are not a homogeneous group, and there are differences. There are differences in terms of how they experience the health system and their reproductive health rights and so forth. We also wanted to look at healthcare policy and protocols to assess the extent to which they are client responsive, that they are responsive to health and reproductive health rights of women living with HIV, and finally to make recommendations to CSOs and policymakers who are advocating for addressing and tackling obstetric violence against women living with HIV in the Caribbean. And like my colleague Richard, Dr. Amelia stated, advocacy is very important. So it was very critical that what came out of this project was evidence that can inform advocacy that's taking place, advocacy for policy and for protocols that are gender responsive, that are rights-based, and that are client-centered. So just to go into what is obstetric violence, and I must admit that when I first started this assessment, I was not too sure exactly what this terminology meant. And it was quite interesting as I got into the study to learn more about obstetric violence. So for those of us who don't know, it is harm inflicted during or in relation to pregnancy, childbearing, and postpartum period. Now, according to CEDAW, recommendation number 19, CEDAW being the Convention on the Elimination of All Forms of Discrimination Against Women, and our Caribbean countries have signed on to this convention. CEDAW states that violations of women's sexual and reproductive health rights are forms of gender-based violence that, depending on the circumstances, may amount to torture or cruel, inhumane, and degrading treatment. So such treatment not only violates the rights of women with respect to care, but can also threaten their life, their rights to life, their health, their bodily integrity, and freedom from discrimination. So in the Caribbean, we have a situation where we wanted to focus specifically on women living with HIV because we recognize that this is a particular form of violence that they face. They face there's a high rate of this violence against women living with HIV because of discrimination and stigma and other social factors that place them at a high level of vulnerability. So in the Caribbean, we have to admit that we've made substantial progress and we've had notable achievements in fighting the HIV epidemic. However, women are still predominantly the ones who have experience, who experience or live with HIV/AIDS. Women living with HIV in the Caribbean are often at greater risk for obstetric violence because they face multiple forms of discrimination, including stigma and discrimination related to their HIV status. And for women who live with HIV who experience obstetric violence, their access to and quality of health care are further compromised. So we have things like, for example, decisions over their bodies, a lack of dignity and lack of safety for those women as they interface with the healthcare systems. So addressing this form of violence is essential to ending the HIV/AIDS epidemic and protecting human rights of all people, their rights to safety, to equality, and the highest attainable standard of health. In other words, obstetric violence represents a barrier to eliminating HIV through compromised access to service, quality of healthcare, and sexual and reproductive rights of women living with HIV/AIDS. And I think this tells us why it's important for us to have a deeper understanding of this phenomenon as we try to advocate for better care for women and to move towards eliminating the epidemic. In the Caribbean, there is very little research and empirical data on obstetric violence. And part of that is because the term is not very well known. This has implications for how we measure and address the issue, especially through policy interventions and in the health system. This absence or dearth of data has raised concerns and the need for deeper understanding of the meaning of obstetric violence, the risk factors, and of course, the different levels of vulnerabilities of women living with HIV/AIDS. Next slide. So the assessment, in the assessment, these are the different, there were many, and it was quite revealing. Some forms of obstetric violence that women living with HIV faced in the Caribbean. So I've listed some here: infringement on their rights to have children, stigma and discrimination, neglect during pregnancy, during and after labor, lack of choice and agency, choice in terms of whether to have C-sections, whether to have more children, whether to breastfeed. They experience that a lot. Breach in confidentiality and non-consensual disclosure of their HIV status, especially sometimes to their partners, to their family members. Physical abuse during pregnancy and labor, verbal abuse during labor, denial of access to family planning, and a lack of healthcare and support. And my colleague and co-panelist, Diana, will speak more to these experiences that women living with HIV face. It was important that the study looked not only at the policy and the healthcare system and health professionals, but also to center the voices and the experiences of the women themselves who are having these first-hand experiences of obstetric violence. Okay, I see my diagram is not projecting as I had planned for it to project, but I tried to show one of the approaches, theoretical and methodological approaches, that was used in assessing and getting a deeper understanding of this phenomenon. And it's called the intersectional stigma. As we all know, in gender studies, and this is in fact a gender study, in gender studies, we use the framework of intersectionality to better understand how different groups of women experience gender-based violence based on their social identity and other social factors. But intersectionality is also used, and it's an important tool that is used by health and stigma researchers. It is now recognized that to analyze and to address and to end the HIV epidemic, we have to have a deeper understanding, and we have to use that intersectional lens. So health researchers use the intersectional lens to understand and address health inequalities among groups at the most marginalized intersectional positions, such as stigma reduction. As such, stigma reduction cannot be fully achieved without centering the structures and the systems that drive stigma and discrimination. Now, intersectional stigma focuses on the interdependent relationship and the mutually reinforcing relationship between social identities and social inequalities that exist. In the context of obstetric violence, intersectional stigma examines the structural and the political domains. So, for example, things like the state, the role of the state and duty bearers, policymakers, service providers, health professionals. So we look at those structural domains and look at the extent to which power dynamics that are rooted in these domains can define and constrain the interests of entire groups of women. So this has important implications for healthcare policy design and reforms that disrupt entrenched power dynamics to ensure quality healthcare for all. So in this diagram, we see that for the Caribbean, these are some of the social factors that interface with women's HIV status and put them at greater risk of experiencing obstetric violence. I found that the age of the woman was a key factor, and I'm sure Diane and her colleague Marissa could speak more to this. Younger women tended to experience more obstetric violence and discrimination and stigma. Marital status as well is important, socioeconomic status. So in some countries, for example, women living with HIV would prefer to go to private doctors rather than accessing the clinics or the public healthcare system. And of course, your one socioeconomic status determines the extent to which you have that option to access healthcare, quality healthcare through other means. So these are some of the issues and factors that intersect to heighten women living with HIV's vulnerability to obstetric violence. Next slide. So in terms of addressing this form of stigma, intersectional stigma that women living with HIV experience, there are some key principles that we have to recognize and we have to bring in to our work around advocacy. And this is why we're here today. We're here to talk about what do we need to do to address and to tackle this problem. So we have to recognize and name systems of power, systems of privilege and oppression, and how they are intersecting to affect individual women's experiences. We have to aim to dismantle those systems of power and privilege and oppression so that we can mitigate the harms that they cause to women living with HIV/AIDS. We have to ensure that community leadership and meaningful engagement exists. And this is what ICW Caribbean Network is doing. They are, through their networks and community, mobilizing, educating and sensitizing and giving women living with HIV the tools to recognize and to speak out against obstetric violence. And finally, we have to support collective action, cohesion, and resistance to address these intersecting axes of inequalities that exist. So what are some of the gaps and challenges in the Caribbean related to obstetric violence? First, which was a very main issue, there's an absence of legislation or legislative instruments and accountability mechanisms to hold individuals and institutions accountable for practices that dehumanize, degrade, and cause harm to women and girls in some of their most vulnerable moments. Women who experience this are less likely to report or to seek justice. So this is not to say we don't have legislation and policy. I mean, there's a lot of policy around reproductive health rights policies, the HIV policy in Caribbean countries, but we still have a long way to go. There are gaps in terms of these policies being nuanced and looking at these various forms of vulnerabilities that women living with HIV face, including discrimination. Another challenge is that many of the support groups that exist on the ground to support women living with HIV/AIDS, they are not legal entities. So they get left out and they get left behind, which means they're not at the table. They're not at the decision-making table. They're not being consulted in policy development and policy processes. And that's a critical gap as well. The lack of data is another gap, and I spoke about this in the start of my presentation. We don't have data, we don't have comprehensive data on this form of violence that exists. And when we do have studies like the ones that we have with UNAIDS and ICW, sometimes the smaller islands get left out. So they are under-researched areas. Women living with HIV/AIDS do not know, again, they don't know what obstetric violence is. So while they may experience it, they may not have the language or the tools to articulate and report exactly what they are experiencing. And I have a quotation here from one of the stakeholders that I consulted, and it was said that women living with HIV, they do not know the term, and therefore they do not know that they are experiencing this form of violence. Many of the organizations make the work of advocates difficult on the ground because they use all of these catchphrases that people who are on the ground are not necessarily aware of or do not know enough about. Next slide. So in terms of tackling and addressing obstetric violence against women living with HIV/AIDS, I've looked at 3 areas that are critical. One is the healthcare system. What is happening in the healthcare system? And yesterday I attended UNFPA had another webinar yesterday on reproductive rights of women and girls. And we heard a lot of the experiences of women and what they had experienced. But the question was raised, what are we doing in terms of our healthcare systems? What interventions are taking place to change what's happening in healthcare itself? So some of the things that are critical is, these are just a few, there are many, but ongoing training of our health professionals. But not just training, but also training using rights-based and gendered approaches so that they are sensitized on how to care for vulnerable and key populations. Because like we said, they're intersecting factors, and women living with HIV experience obstetric violence in different ways based on their social identities. HIV status being one, but also things like if you're a sex worker or if you are a young single woman, these are other issues, factors that must be considered, and there needs to be ongoing training on how to care for these vulnerable and at-risk populations of women with HIV. Policy and protocol, of course, that is important. It's important for us to look at what exists in the Caribbean. There are lots of policies and strategic plans in Caribbean countries, but we need legislation because legislation gives teeth to policies and plans. We need to hold people accountable. We need legislation that is non-discriminatory, right? We also need policy and protocols that speak to the right to consent, the right to liberties, privacy, right to refuse. Women have the right to refuse and the right to have agency when it comes to accessing reproductive health care. And then finally, but not least, this is very important, and I will end here, and I will hand you over to Diana because she can speak very well to this issue. We have to look at our CSOs and CBOs and the advocacy that they're doing among communities of women living with HIV and networks of women living with HIV, because they're the ones advocating, giving voice to the issues. We have to bring in awareness to the issues that women face. We have to help build the capacity of these CSOs and CBOs. We have to encourage collective mobilizing of women. Their experiences and voices need to gain greater prominence, and this webinar is an important first step to discussing and being aware of the issues. And we have to ensure that we are monitoring what's happening in terms of policies and making sure that policies are more responsive and respectful to the rights of women living with HIV. And I will stop for now and we can continue in the Q&A segment. Thank you very much.
Thank you very much, Dr. Motley, for that presentation. We're going to continue, go straight ahead to Ms. Diane Weeks, who is going to be our next presenter. Before I present to you, Diana, I would like you to know that she holds several positions in leadership in the fight against HIV/AIDS. She's the director of the Caribbean Regional Network Positive People, CRWS, the interim chairperson of the International Community of Positive Women in the Caribbean, ICW Caribbean, and the chairperson of Trinidad and Tobago for Positive Women, TCW. Additionally, she serves on the National AIDS Coordinating Committee, NACC. Diana is pursuing a bachelor's of arts degree in psychology to become qualified to help people living with HIV with their mental health. Well, Diana frequently lectures at various agencies locally and regionally on HIV/AIDS. She is a champion of issues related to women living with HIV, especially their sexual and reproductive health rights, as well as overall human rights for people living with HIV. Currently, Diana is leading the implementation of the Stigma Index 2.0 in Trinidad and Tobago. The survey is due to be completed in late 2024. Additionally, she coordinated and recently concluded assessment of the vulnerabilities of women with HIV, assessing maternal health care, and this assessment was funded by UNAIDS for 4 Caribbean countries. And no further ado, let me present to you Ms. Diana Weeks. She's going to do a presentation called Hear the Women.
Good morning, everyone. I make apologies in advance. I have limited voice capabilities, but I will try my best. Today, we gather to present the findings of the crucial assessment, which amplifies the voices of women and girls living with HIV in the Caribbean. This issue came to light when ICW Global had a media team, and this media team comprised of young women across the globe, and they were looking at different issues which could be highlighted. And so a conversation about obstetric violence began, and the young representative for the Caribbean, Kimberly Springer, she came back to us and said, um, and we would have support groups, and she would recognize that a lot of women would speak to these issues. However, she never had a term for it. And so this began the journey to, developing the concept note, advocating for resources, and carrying out the assessment. And now here we are today. And basically, this assessment sheds light on the experiences and sexual and reproductive healthcare settings, revealing both challenges and opportunities for improvement. For too long, our approach to HIV programming has been gender blind. It fails to recognize the unique needs and experiences of women and girls living with HIV. This oversight has led to initiatives that, while well-intentioned, often fall short of addressing the nuanced realities faced by women and girls living with HIV. As the Nigerian author Chimamanda Ngozi Adichie powerfully stated in her TED Talk, stories matter. Stories have been used to dispossess and to malign, but stories can also be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. Today, my colleague Marissa Gemot, who will be assisting me because of my limited capabilities with my voice, will present stories that have that power to repair dignity, to humanize the experiences, and to drive change. The women and girls who have shared their experiences for this assessment have entrusted us with their narratives, their stories of stigma, of discrimination and mistreatment, but also the stories of resilience, hope, and the desire for better care. These stories underscore the critical need for gender responsive programming in HIV initiatives. It reminds us that women and girls living with HIV face unique challenges that demand tailored solutions, from issues surrounding confidentiality and consent to experiences of obstetric violence and limited choices in infant feeding. These narratives paint a vivid picture of the gaps in our healthcare systems. And I want to point out that we also need, while my colleague Dr. Motley would have spoken to policies, we also need to be mindful of the practices, because sometimes there is disparity between policy and what actually happens in practice. And as we delve into the findings of this assessment, please let us remember this is not to point fingers, but that behind each statistic and each recommendation is a real person, a woman or a girl whose life is profoundly affected by the policies and the practices that we implement. Their stories matter, and it is our responsibility to ensure that these stories inform and shape our responses. This regional presentation is not just about sharing information, it's a call to action. It's an opportunity to reimagine our approach to HIV care and support for women and girls. It's a chance to commit to programming that is truly gender responsive, that recognizes the intersectionality of women's experience, and that upholds the dignity and rights of all individuals living with HIV. As my colleague proceeds, I urge each of you to listen deeply, to engage critically, and to consider how we can translate these findings into meaningful action. Let us please use these stories to empower, to humanize, and to repair dignity. Let us commit to creating a future where every woman and girl living with HIV receives the respectful and comprehensive care that she deserves. And so I will now pass over to my colleague, Marissa Jamat. Marissa is the Secretary for the Trinidad and Tobago Community for Positive Women, and she assisted along with the coordination for this study in the 4 countries. Marissa.
Hi, good morning, good day, everyone. It is indeed a pleasure to be here. So while we do that, I am just asking for the opportunity to share my slides. Can I just get a bit of assistance for that? I want to thank Dr. Motley for leading the way in terms of, starting the conversation. And I would warn that some of the content that I would present may be a bit graphic, but I wanted to paint a true picture of really what the woman would have shared with us when we conducted the assessment. So let me see if I can share my screen. Yes, so I can show up. Hold on, just give me a second. Right. So allow me to start. All right, so I'm going to skip through a couple of the slides because it's really, we would have spoken about it. So as mentioned, the assessment took place, oh, hold on. I'm having a little challenge here, just bear with me. Just let me stop share my screen. Sometimes when you're thrusted in the heat of the moment, you know, you just have to answer the call. So this is me answering the call to assist Diane with the presentation. So just let me see why the screen is giving me such a problem. Just give me a second. All right, I should be good now. So yeah, so back to sharing my screen. All right. Yes, so as mentioned, this project was done in 2023, September 2023, where the assessment took place with 4 countries. So this is Guyana, Jamaica, St. Vincent and the Grenadines, and Trinidad and Tobago. I must thank UNAIDS for answering our call to have us be part of the assessment, because we felt it was really important to amplify the voices of the women, to actually share the lived experience, so that, you know, there will be a better understanding of how the treatment affects or how it works in relation to a real-time scenario, right? The project objectives looked at women, the lived experiences for women within the last 5 years. So we would have polled or gathered women who would have given birth between 1 and 5 years from 2023. All right, the specific objectives of the assessment were to conceptualize obstetric violence against women living with HIV, assess their risk and vulnerabilities using available framework and evidence, and produce recommendations for civil society organizations and policymakers to address the issue. Specific again, we wanted to be able to define and conceptualize the concept of obstetric violence, to identify and assess the factors that place different groups of WL-HIVs at risk for obstetric violence, including those secondary sources, data information provided by women organizations representing the target population. Another one of the objectives was to review the policy framework, which was done by Dr. Mobley and her team, and of course to be able to produce recommendations for CSOs and policymakers to advocate for and address obstetric violence against women living with HIV through gender responses, policies, protocols, programs, and better client-centered support. So this is me going directly into the findings. So one of the key findings, and I will start with on a positive note, when we asked the women to share about, you know, what were their experience, we had some positive responses. So many women spoke about having positive experiences in the context of their sexual health and reproductive rights, and their experience at the maternal health care facilities. And in all the focus group discussion, when asked whether they had experienced a specific range of mistreatment or abuse, most of the participants said no. However, we also asked, we wanted to understand or get an understanding of whether women are aware of their reproductive health and rights, and we found that there was actually a gap where women knew what U equals U was, but in terms of understanding how it applies, that remained a challenge. So many of them were aware but didn't fully understand implications for their reproductive health and rights. On an overall, participants had limited knowledge of their rights. A number number were able to define their rights in terms of, for example, defining certain types of treatment which had left them feeling isolated, ashamed, overpowered, or humiliated as infringements of their rights. Others had an awareness of stigma and discrimination as a human rights violation and were active in sorry, you have to bear with me, I have a bit of a title, in countering it. A number also spoke about gender-based violence perpetrated by partners or family members outside of the healthcare setting. So I'm going on to the negative experiences that the women expressed that they would have experienced. And across the countries, there were examples of poor treatment, a lack of accurate knowledge or sensitization on the part of healthcare providers, breaches of confidentiality, especially related to HIV stigma and discrimination, and neglect and abuse. Women also shared of experience of poor health worker attitudes, being told off, and you'll find me using a bit of the local colloquial language, because I really want to paint that bigger picture. Having to wait longer times than usual, and they attributed, sorry, bear my title again, this to being as a result of being HIV positive. So many times they were left isolated from other patients. Another key finding, breaches of confidentiality. Breaches of confidentiality and non-consensual disclosure of their HIV status were issues raised by many of the participants. Often it was described in terms of the health workers simply speaking loudly when discussing things about the participants. So what usually happens, especially if you understand how the hospital setting is, it's usually small confined spaces, and you'll find the healthcare provider, rather than using what we would call the inside voice, using a very loud tone, and obviously with they're not having that soundproof facility. Once you walk out the door, everybody knows, okay, you were getting that conversation. All right. Also, the act of butter feeding. Women felt that they were singled out when they were on the ward after having their babies. All right. Okay, so this was not supposed to be there. Okay, so another finding, family planning and facilities desires was another issue that was identified, and there were mixed responses in terms of the experiences. Some said they had good experiences, others said that it was really difficult, and sometimes they felt a bit ashamed. So, and I'm going to use an example for family planning was not that as easily shared, because once you are HIV positive and you go to the health center or you go to the hospital to access care, one thing they try to always come at you with is abstinence. So I think in this statement, the whole concept is, okay, HIV positive, then you should abstain from having sex. When, in reality, sex is a basic human need. And so, being told that you shouldn't have sex because you're positive is something that the woman highlighted. And this was a comment that came out of Trinidad and Tobago. That person was even told you should not have sex any long and short because, you said, why you want to be having children? And, the person responded, well, I am still a human, right? Another comment, family planning. Okay, so this is the same comment. Yeah, so the other comment to this findings, few participants shared stories of being pressured to use long-acting family planning methods or being advised not to have any more children as a result of being told off by the healthcare provider. So in this case, would be the doctor or the nurse, especially if it's not their first time having a baby. So another finding, pressure regarding to tubal ligation. Women living with HIV face contradictory pressures that can vary between being forced to adopt a particular type of service related to their SRH lives, such as long-acting methods of contraception, in this case, tubal ligation, and other times being denied. Several participants described being advised to have tubal ligation to ensure that they won't have any more children, even though that at that stage of their life they don't want to. So there was a heavy level of pressure being placed upon them to have the tubal ligation. We also have women reporting instances of physical abuse during pregnancy and labor. A number of participants shared experiences of being or having to wait or being kept waiting long hours, especially presenting in the hospital during labor. And this one participant from Guyana recounted that, you know, she presented to the hospital in labor, and she literally had to wait until a doctor came to see her. But at the same time, she is in active labor, right? And she eventually, you know, found a way to get but she more or less told them, listen, I am in labor, I am in pain, I need a bed. All right, so this particular person literally went, she had to fight to be able to get help, or else we're not sure what would have been the complication if she didn't decide to say, listen, I need help. All right, another participant, and this person from Trinidad and Tobago, spoke about, you know, she, while during labor, well, of course, she bit her tongue and waited until after she had her baby to be able to have a conversation with the nurse, you know, about what she felt was wrong with how she was treated. Unfortunately, her at the time not understanding that this was a violation, never reported it. All right. However, this obviously impacted how she felt about having a baby or even presenting to the healthcare facilities, you know, for pregnancy. We also had a participant expressing the fact that what midwife told her, you know, why at this time, why you're calling God, you know, when, you know, you was lying, God wasn't there. And I mean, I know it in our colloquial language, it sounds like a bit of pecan, but when you look at the statement, it is a verbal abuse, right? We also had women talking about experiencing neglect during pregnancy, during labor, and even postpartum. A number of women described experiences of neglect after having given birth, which can be categorized as mistreatment, abuse, or violence. These include refusal to clean women's stitches. So there were women who would have had to do a cesarean as part of their pregnancy because for whatever reason they couldn't deliver vaginally. Women having issues of not getting assistance with changing their colostomy bag, or even simply being assisted to go to the bathroom to attend to their other basic needs, right? And one woman from Guyana and even one from Trinidad and Tobago described that, you know, after having a C-section, and they came and just, you know, handed her the gauze and everything that she needed to take care of herself and said, here, do it yourself, you know. You also had, you know, one that particular, and that was the person from Guyana. The person from Trinidad and Tobago decided, listen, it's my baby, it's my body. I'm in pain, yes, but she had to do it herself, and this was for her last child because there was nobody else to help, right? And in listening, as I'm sharing these conversation, I remember being a part of this particular focus group discussion, and thankfully we had trained social workers and persons who can actually, you know, help these women process, because it's like we were bringing up old wounds of what they've experienced, right? Another finding that came out of our assessment is when we look at infant feeding, there was a lack of choice, lack of support, and again, instances of involuntary disclosure, right? And this was the biggest and most complex issue that came out from the study by the participants, in that there was issues with infant feeding. Now, I mean, it's a Caribbean thing. We usually say breastfed is best fed, but of course, in the Caribbean, once you're HIV positive, most instances are that you are told not to breastfeed, right? And when we asked, that was a question, I remember asking that question several times. Yeah, they were told that the better option, or the safer option, for mothers living with HIV, regardless of the fact that you're undetectable, your viral load is low, your CD4 count is good, that they are advised, or strongly advised, that the safer option is to bottle feed, and given, use formula to raise their babies, right? This raised a range of issues for women, from sadness to missing out on what they saw was an opportunity to bond with their newborn, fear of actual experiences of involuntary disclosure, because what happened, when you're in maternity ward after giving birth, there's that joy of being able to have your baby latch on and breastfeed, and then you're looking around the room, and then you have to bottle feed, right? One participant shared that, in bottle feeding, instead of breastfeeding, it triggered an incidence of domestic abuse for her, right? One of the things that would cause gender-based violence is when, women, because of that fear of sometimes telling their partner, the gender-based violence tends to pop in, or domestic violence tends to happen, because, the partner wants to know why you're not breastfeeding, right? And that, in a nutshell, really was some of the noted experiences, and of course, we sum them up into themes. So I'm actually going to go into the recommendations, and we group the recommendations into 4 categories. So we looked at recommendations based on educating families, communities, healthcare providers about HIV, because in 2024, we are still finding instances where healthcare providers do not know the updated information as it relates to HIV. Family members in the community, still do not know what are the updated information as it relates to HIV. We also recommended from our assessment to ensure that healthcare providers provide respectful care to women living with HIV. And I will talk a little more about this when I speak about the advocacy that's still ongoing from this assessment. Ensure that women receive appropriate information, choice, dignity, and care around infant feeding. And I know there's some countries that are working towards the elimination of mother-to-child transmission, and so having women getting the opportunity to breastfeed is a process that I think in most instances, lacks the policy and the support to ensure that women can successfully breastfeed, and even give the woman the information of her choice. If you can't breastfeed, this is the process, this is the support, right? Invest in women's group to provide information, support, and to champion rights, and that is at the helm of what ICW, and by extension, because I'm representing Trinidad and Tobago Community for Positive Women, TCW, that is what we do a lot of, championing to ensure that women have the support and their rights are not infringed, right? I'm moving swiftly into talking about what was proposed as advocacy strategy, and we looked at launching and sharing the assessment throughout the hosting of the webinar. I know this webinar is part of it, that we had proposed, so that we can share the information and actually initiate bigger conversations around how we can actually eliminate obstetric violence. We spoke about having a leadership, advocacy, and movement building workshop. We discussed having the ICW Young Advocates Media Program, and of course, lobbying for special curriculum to develop and implement for the training of interns in the medical and social work fields, and by extension, the support around healthcare providers. So where are we now? So I know for two countries, Jamaica and Trinidad and Tobago, we would have had a couple of the leadership, advocacy, and movement building workshops where we would have brought together key healthcare stakeholders, which included like the Nursing Council, the Midwife Association, and key stakeholders, Ministry of Health, or the NACs, to first present the findings or present the report and then discuss with participants from the focus group discussion, discuss what happened and discuss the experience. So we'll actually have two sides having a conversation about what really happened and how we can make it better. Currently ongoing, I would have been happy, and I have to use the word happy, to say that when I sat in on the meeting of the advocates, so what we did is we actually had two persons from each of the countries, Jamaica, St. Vincent, Guyana, Trinidad and Tobago. They came together, these women came together and they discussed how they, well, of course, after sharing the report with them, we discussed, okay, what do you want to see? What do you want to do? How do you want to make an impact to show that, listen, obstetric violence has to end, it cannot continue, share light. And it was really exciting to see how they came together. I mean, many times these women, they would have met for the first time at that online meeting, and they really went through and developed the campaign. So it's in process right now. I suppose within the next couple of weeks, you'll start seeing the social media being flooded with content that they created and they were part of coming up with the taglines and coming up with the things that they want to say. And one of the things that was really strongly advocated is that, listen, obstetric violence has to end. We as HIV positive women deserve to have, a dignified life as mothers. We decide we need to have a dignified birth. And they were really vocal about this. I was really happy, and I heard a couple of the messages, and I'm excited to see the launch of this campaign. And I know some lobbying has begun in terms of, looking at a special curriculum specifically related to dealing with issues around obstetric violence and, training the interns about how to treat women who are HIV positive and, bring about that whole change that we're advocating for. So this in excess is not started, but a stronger call to action is needed, where we need to have regional conversations around really wanting to make the change. And as Dr. Murphy mentioned, looking at policy. So even if we start at the schools or start at the university, where these medical persons and social workers or persons who work in the social sciences field are trained, I think a wider call to action where the key persons who are stronger lobbyists can really put together something that would really make an impact for the women. And I think in a nutshell, that was my presentation. I hope I wasn't too fast. But yeah, I'm passing back to Pauline.
I want to thank you. For that comprehensive report. And so one of the call to actions we would really like to see is a regional discussion around, specifically with partners like PAHO, PANCAP, CDC. How does the EMTCT align to the baby-friendly and the safe mother initiatives, and how applicable is it to women living with HIV. So these are one of the call to actions that we would really like to see happen um, in the near future. Thank you.
Thank you very much, Marissa Jamont and Diane Weeks, for your presentation. If you have any questions, please type them in the section remark for questions, and we will try our best to have them answered. Thank you both for your presentation, Dr. Natasha Motley, and of course, Dan Weeks and Marissa Jamont.
You're welcome.
Richard, may I ask a question, please?
Auntie, yes, Auntie, go right ahead.
All right. Thanks to all of the presenters. Really, really very interesting findings from the study. I think, as Dr. Natasha shared when she started her presentation, this was sort of new, but once you got into it, you found it really very interesting. I think it's the same that's happening with me. But I did a little bit of a research, and what the research is showing is that there isn't a difference in obstetric violence for the general population or women broadly when compared to women living with HIV. And I noted the findings that you have. I am particularly intrigued by the one on breastfeeding, because when I wrapped my mind around obstetric violence, I sort of pivoted on the health sector. But then if you think about obstetric beyond delivery and you think about breastfeeding, that's sort of a different dynamics that comes into play with interpartner violence, etc. And while I'm aware that the discussion did happen primarily among women living with HIV, I wonder what is your thought around obstetric violence broadly for all women?
So thank you for that, Shanti. And I remember, and there was we were doing a training in Trinidad for PrEP, and at the point in time, the discussion came up about obstetric violence, and there was someone there who was sharing, and strangely enough, she is not a woman living with HIV, and she too, as far back as 15 years ago, had experienced it. And so we do know that it is not limited only to women living with HIV, but women across the board. And so it speaks to the practice and how and the approach um, our healthcare professionals and public health has in terms of patient-centered care. So I don't know if Dr. Motley wants to chime in as well.
Yes, Diane, thank you. I agree with you that women broadly do experience obstetric violence in the Caribbean and globally. Yesterday, for instance, the webinar that I attended, there was a woman sharing her lived experience, but she was discussing her experiences in a hospital when she gave birth based on her race, racial relations in America as a black American woman. So it is experienced broadly, but I think women living with HIV experience obstetric violence differentially. I think they experience it in different ways. And one of the main factors is that stigma that is attached to living with HIV/AIDS. We cannot deny that there is stigma even within the healthcare system, which is intended to provide the quality of care for women, which is intended to respect women's, right to health, to access to good quality health. So there is that stigma that exists. And I think that is why health researchers and medical researchers have adopted this intersectional stigma lens in their work. So it's important to see how that stigma, I mean, there are international protocols on how women living with HIV should access healthcare. There are protocols. But when we dig down on, the cultural context that we're operating within in our Caribbean societies, when we look at the socio-political dynamics of our Caribbean societies and communities, we have to recognize that the treatment on the ground, like you said, Diane, what's happening in practice, it's different. It's different, and there's some real issues on the ground. There are women who have not revealed their HIV status to their partners, right? But they're pregnant, they go to access maternal care, and that their confidentiality and privacy, there's a breach because a health professional says something like, you're HIV positive, why are you having children, or why are you having more children? And that creates further dynamics because now the partner is suddenly aware of something that that person was not aware of before, and it creates, like Diane said, a situation of domestic violence within the home, violence, intimate partner relationship, right? The shame that women with HIV face and experience. They are in healthcare spaces where women who do not have HIV/AIDS are being treated differently, and they can see it. They can see it firsthand. So while women broadly experience the phenomenon, I think we have to recognize the social identity, the differences in terms of social identity, those gendered issues that are at play, and cultural issues as well. A culture of whispering or talking or facial expressions when a woman enters a clinic. We have to recognize those things that exist as well.
Thank you for that question, Shanti. I see Gillian Mason has a hand up. I don't know, Gillian, you can unmute yourself and ask your question or type it.
Morning, everybody, and thanks very much for the presentations. So I do research in violence against women, so obviously it is of interest to me. And I just had a comment and a question. Following up on what was just raised about the fact that, the occurrence of obstetric violence is, of course, within the wider remit of just violence against women, that in thinking about, while I agree with the previous speaker or questioner, that there is obviously obstetric violence against women, regardless of their HIV status, etc. When we think about fighting it or addressing it, I think that it can be used, recognizing that it occurs against women, that in working with the healthcare providers, to kind of try and not have them be overly defensive. If we talk about it in the general context, so for instance, when Ms. Marissa spoke about the fact that women, when they're going through their birthing, and these kinds of comments, very negative, abusive comments that they will experience, that unfortunately happens with a lot of women generally. And so I'm just thinking about whether, when we are doing the education, if we take it from the broader point of view, meaning this is how people should be treated, right? And then, as Dr. Mortley pointed out, that there are things that are specific to different groups, including women with HIV, that we then also hone in on it. So it's just a suggestion I'm making in terms of, as you're talking about, where do we go from here and setting policy. So that was my comment. My question, though, from some work I'd done with healthcare workers focused on again, stigma, not with women with HIV, but around gender identity. One of the things that we found was that the patients experienced a lot of stigma, not just from the healthcare providers, but from persons who work in the healthcare system. Well, I'm in Jamaica, right? So security guards, the receptionist, you know. So I wondered if you found that as well in your research. So I just wanted to find out about that. Thank you very much.
I can answer to that because yes, it's not just limited to doctors and nurses. However, because our focus has been on the maternal journey, we spoke highly about that. But in other conversations, we can tell of instances where the security guard, the cleaners, so the added support that usually supports the key stakeholder, the key healthcare professional, so the persons who clean the room, the janitors, the security, yes, they too contribute to the stigma and discrimination, or the stigma that the woman experience while going through that maternity.
And if I would also like to share, sorry, I am unable to turn on my camera this time. I know that Yui would have done some work across the islands with some countries with stigma surveys for healthcare professionals. And those stigma surveys would allow, just like the stigma index gauges stigma and discrimination experienced by people living with HIV. Those stigma surveys allowed for gauging um, the stigma and discrimination um, by healthcare professionals. Unfortunately, it has not been done in Trinidad and Tobago yet. It hasn't been done in all countries. So, in order to be able to address from the multi-level, we need to be able to have that data first. So, and I always say you have to first understand the magnitude, the scope of the problem, where exactly it resides, what it looks like before you can create programs to efficiently address it. And so that may be another step that we look at, perhaps measuring stigma and discrimination from the healthcare providers.
Mhm. I also want to jump in and agree with Julian's point in terms of our approach to legislation and policy, and of course, guidelines. I think we do in the Caribbean, we do have a call to action in terms of ensuring that we have the mechanisms in place, we have the instruments in place. We need to insist on legislation. We have a lot of policies that are in train or in progress related to reproductive health and HIV. We have a lot of strategic plans that are in progress in our countries, but we have to move the needle further. We have to insist on policy. We have to insist on legislative reforms. I mean, we have examples of legislation in other parts of Latin America, for example, Venezuela has good legislation on dealing with violence against women as it relates to reproductive health rights and so forth. So by omission, we are neglecting a problem of obstetric violence for all women. But we also have to go further. Once we have these frameworks in place and we have these mechanisms in place, we have to go further to ensure that we are doing consultations with the right groups of women, that various groups of women are at the table, have a voice, and are influencing these instruments so that they do not remain discriminatory. So by omission, we still have a lot of work to do to ensure that these things are put in place as a general framework. And once they are in place, we have to go further to ensure that they are in fact responsive to the differential needs of women, including women with HIV.
All right, thank you very much. I have a question from Telford Lane. Telford, I see you have your hand up. You could ask your question.
Good morning, everyone. I think this has been a breath of fresh air. I must commend you two on the team for this. I've observed this a while ago. I think when my wife, we had our first child 23 years ago. You go to the hospital and all these silly, degrading, humiliating remarks. Um, I'm a clinical and a developmental psychologist, and while I'm aware of it, I can't coin it just as how you guys coined it. Very, very, very unique. I think this begins a movement under the correct labeling of getting it changed. I hear you guys talk about policies, and I'm wondering whether that might be the better thing or the better way forward because. Um, in Guyana's context, you still hear these silly remarks um, by midwives and nurses, especially when you go to public health institutions. But when you go to the private institutions, you don't see traces of these. And I guess because they are investing in their staff as to how to relate and to deal with people, thinking that they're paying their money and therefore they have to have quality service. But then in the public sector, um, it's the most toxic and traumatized place for a woman to go during our pregnancy. So for me, I don't know if policy will work. I think maybe re-education and making it make having women understand the traumatic effect on the lives of women's mental health when they are most vulnerable, which is during pregnancy, and appeal to the empathy or something to that nature so that we can bring about this change. But kudos to you guys. I really love this. This was remarkable.
Yeah, thank you.
Olive Edwards, I think, has a question. Olive, you can unmute your mic. All right, I don't think Olive is.
I'm sorry, I have no intention
Oh,
of talking. This
all right,
is
that was a
triggering.
mistake.
It's triggering and emotionally not something I can discuss in this forum. I listen.
Okay, Olive, thank you very much. Are there any more questions or comments before we bring this to an end? Okay, seeing there are no more questions or any more comments, I'd like to thank you all for attending and, of course, the presenters for presenting such informative information. To close us off today, I would like to ask the Coordinator of Knowledge Management at PANCA Coordinating Unit, Dr. Shanti Singh Anthony, to give us a brief wrap up. Over to you, Shanti.
Yeah, thank you. Thank you, Richard. Let me start out by saying a big thanks to our presenters. It was Telford who just said that this has been phenomenal and this is the start of a movement, and I'm beginning to really feel that way. Um, I really do appreciate the comment from our Jamaican colleague who put on the table an approach or recommendation to really addressing this issue. And while we acknowledge that this is an issue facing women broadly, I think we're very mindful that women living with HIV have special circumstances, if I can call it that, that put them at even higher risk for these types of violence. And while there is the recommendation that we can look at this from a very broad-based position of all women, I think HIV has in the past has led many initiatives, and I think here's an opportunity for us to really push on this, as Telford said, let this become a movement. And so I want to thank both of our presenters. Thank you for reminding us of our commitment to the CEDAW Convention. We, as countries, we have signed up and we've made a commitment to eliminate violence and discrimination against women living with HIV. I really do appreciate the actual examples that were used in the presentation to demonstrate that when we talk about obstetric violence, that this is real, and this is real, and it affects real people. It affects families, it affects the pregnant mother, it affects the baby to be born. And so this is real. And so we really need to be able to onboard some of the findings that you have come up with, but some of the recommendations. And so I want to again thank all of our presenters on behalf of Dr. Wendy Emanuelson Tagelt, our PANCAP director. And on behalf of the partnership with everyone who were here today present and were able to participate in this discussion. Again, I appreciate the conversations, and I want to close by saying this is the very beginning of a movement, and so let's keep moving. Thanks again, and over to you, Richard.
Thank you very much, Shanti. I want to thank all the participants for attending, the presenters for presenting, and of course our special guests who brought greetings. Thank you all for being a part of this webinar today. As we all say, it's the beginning of a movement, so I'm looking forward to see you all soon as we continue to take this process forward. Thank you very much and have a great remainder of the day.
Thank you. Bye-bye. Take care,
Bye,
everyone.
everyone. Bye.
Thank you. Bye.